Hello everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Avik O'Kelly. This week, we will hear the keynote address from Dr. Sean Keenan. He was invited to speak at our Medicine in the Mediterranean conference, and here is his keynote presentation.
Thank you all for having me here. I want to thank Horan, Avik, John Clark, the coordinators. Thank you for having me here. So just by a show of hands, I know you're doing this, but this is audience participation. How many people have heard the term prolonged field care? Cool. Okay, so if I ask that question probably about 7 or 8 years ago, we may have had about 1/3 of the audience. And I'm talking about with special operations, military. And I would venture to guess that if we were in the same room, perhaps that wouldn't have been the case. How many people have heard the Prolonged Field Care podcast? Great, okay. So I think that is evidence that we designed something specifically for one small group of people, but by leveraging technology, we were able to get the word out a bit. And the lion's share of that work is being done, obviously, by Dennis Jurema and Paul Lose and some of the other folks behind the scenes there. But yes, I am a colonel, retired. The reason I'm in Malta is because my beautiful wife said that this is where we're coming. So, no, but I kind of use that retired, but it's kind of a little bit of a joke because I pursue what's kind of my medical hobbies, trying to push things that I think are best practices from the tactical level up through strategic and international levels here. I have a couple of fancy affiliations. I do work as an advisor to a military research group at the University of Colorado. I'm from Colorado Springs, so by show of hands, how many people have been to Colorado? All right, we actually have people there, yeah. It's a little bit warmer here. It's actually nice. Walked around, found the sunshine today. And we'll talk just a little bit about specialized medical standards, of which Avik is on the board. Eric Holmstrom here is an instrumental part of pushing the word here in Europe. I want to do a couple of introduction disclaimers, conflicts of interest. I do have an interest in conflicts. That's why I work for the Joint Trauma System. I think it's important to know whenever you hear a speaker, and when you hear a speaker, the first thing you say, well, why should I listen to this person? I'm one person, and I just want to give you my biases right up front. I'm an emergency physician and also an EMS subspecialist. In some of the countries out there, that may be an anesthetist or something equivalent, but in the United States, we have emergency medicine. In the United States, we do not have physicians going forward into the pre-hospital space, whether that be necessarily in the military or on the civilian side, unlike some of your countries that are out there. But we actually enable our paramedics and our paraprofessionals in the pre-hospital space to go forward. And so I spent the balance of my career being a medical director for those folks going out and doing many of those hard jobs. It was my job, and still is my job, to provide top cover, to provide education and training for those individuals. And I'm extraordinarily proud of the work that the folks that I've been able to enable and provide top cover from, and still do. I'm a consultant for the U.S. military for the Joint Trauma System, which, by show of hands earlier, you are familiar with it. The Joint Trauma System is unique in that it's not necessarily that they're, correct. It's just that we unfortunately had a lot of experience over the last 2.5 decades, and we still are involved in conflict. We being the United States, the United States Department of Defense. But some very smart individuals at the beginning said, we can't continue to not learn the lessons from our injured folks, from the people who are being injured and dying. And so this organization, which has grown tremendously over the past 2 decades, actually collects information. We're able to study every single person that's been injured, whether in conflict or in peacetime in the United States. And we put together a database, and that's called the Joint Trauma Registry. And it is biased towards our experience over the last 2.5 decades. Now we're trying to capture what's going on right now in current conflicts, but at least using this, we're able to put out best practices. Best practices in what we call in NATO Role 1, or pre-hospital care. And you probably know that by the Tactical Combat Casualty Care guidelines. And then they spun off the Tactical Emergency Casualty Care guidelines. for civilian use. But essentially they're on the same principles. Well, what's most important, I think, is that we're able to capture from the point of injury all the way back, what are the best practices? Now, of course, it's kind of incomplete on the pre-hospital side, but at least that's where we get that from. And we have a bunch of dedicated people still to this day that study every single case of people that get hurt in the United States military overseas, and we try to put that into best practices. What's more, we listen to what's going on, specifically in Eastern Europe, and we try to piece that together as well. But it's important to know that I take a US perspective. Doesn't mean it's necessarily right, it's just my bias and where I come from. I'm also currently a medical director in Teller County in Colorado. See some of my colleagues here, like Nick Stuber and those guys. They work for the second best rural medicine system. I'm a little bit biased, guys, but a little healthy competition never hurt anybody. So now I got some folks from Colorado here.
At least we're better looking.
You are better looking. You have better swagger and better hair, I must say. So. I'm also a chief medical officer for a small training company. I got together with a couple of my colleagues called Ragged Edge Solutions. We train specifically and mostly special operations. We train some NATO countries as well. And through that, what we learned by teaching prolonged field care best practices, we spun off a civilian company called Specialized Medical Standards. And at that time, we realized the Prolonged Field Care website and the podcast at the time had a little bit of a struggle getting the support they needed. And so we brought them under our nonprofit. Abrick's on the board, we have some other folks on the board of that nonprofit, but we developed that, of course. And then we spun off a civilian course called Austere Emergency Care. By show of hands, anybody heard of Austere Emergency Care or been through it? Oh wow, okay, great. Well, hopefully in 5 years I can have a few more hands up here. So anyways, that's kind of my perspective there. What's the objectives tonight? Abrick and John asked me to go ahead and talk about kind of the past, the present, and the future of prolonged field care. I'm going to talk a little bit about the development. We mentioned briefly the CPGs, position papers that we came up with. And by we, I mean it's like me and 140 of my closest friends. Okay, I continue to do this, maybe I can't get away from it, but as we develop these position papers and clinical practice guidelines, we actually brought in a lot of different subspecialists. If you notice on many of our clinical practice guidelines, the first author and the majority or half of the authors are medics, special operations medics. I insisted upon that on most of the papers because what we absolutely needed to know was what was going on in the pre-hospital space. There's nothing that drives me more crazy than to have trauma surgeons or hospital-based people writing guidelines in a vacuum for pre-hospital, right? Because of course, once the patient gets to you, of course, when you lay your hands on them, they're going to survive, right? And if they didn't, it wasn't your fault. No, just kidding. But the bottom line is there's actually a survivorship bias when you look at most trauma literature. I mean, they only study patients that make it to the front door of the hospital. But there's a whole lot that happens before you get to the hospital. Unfortunately, a lot of our literature is skewed towards those trauma patients. And when you study what's going on in the pre-hospital space, you absolutely have to understand who is writing that paper and what is their perspective. Where are they getting their data from? There's a huge gap right now in Eastern Europe where we do not have good data as to why people are dying. We know a lot of people are dying. And I don't mean to say that we don't know certain things because we've got a tremendous amount of information. But we don't have a lot of scientific data to tell us exactly in certain areas how people are dying. And I know that there's a lot coming out. I see John here and other folks that are putting the word out. But bottom line is getting real data in the pre-hospital space is difficult. I'm going to talk about PFC and the civilian education efforts, and then I'm just going to give you my opinion in a couple of short slides in the future. So we talk about the past. Of course, we've been doing austere medicine for a very, 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 very long time. 2013 was not the beginning of austere medicine for the US. But 2013 was kind of a turning point in special operations, I think, because we were so heavily biased towards the first 30 minutes of care because we had pushed almost all of our military troops into Afghanistan and Iraq. And we had the best trauma system ever deployed. And in fact, if you got blown up or shot in Afghanistan, you had a way better chance of survival than if you were in a car accident in rural Colorado. That's a fact. We had a robust pre-hospital system. We had a golden hour policy where everybody, or 75% of people, made it to a trained surgeon within 60 minutes. I would challenge you to find those numbers anywhere in the rural United States today, or anywhere else where you might practice. But back in 2013, we had a problem. I was the medical director of the 10th Special Forces Group. I had been in 2 other Special Forces groups previously. By then I had 5 combat deployments, and I was the head doctor in the 10th Special Forces Group. And just to give you a little bit of perspective, in our Special Forces, we have 7 groups, 4 battalions in each group, and I had 140 paramedic 18 Deltas just in my group. A lot of highly trained individuals. And they had been going to Iraq for a decade. They were really, really, really good at the first 30 minutes of care. And then I got there in late 2012, and in 2013, my medics came back and they showed me pictures and they said, "Doc, this was my last deployment. This is sub-Saharan Africa in Niger." And some of you may be familiar with this area, but in sub-Saharan Africa, you can drive for 2 or 3 or 4 hours like that and not see anyone. And again, they weren't necessarily being shot at or blown up right there, but they were experiencing car wrecks. And my medics were coming back and telling me, like, "Hey, no one really gave me a plan. They gave me one PowerPoint slide. They never gave me a plan. What happens if somebody gets hurt?" Well, if somebody gets hurt, you're gonna call for medical evacuation, right? And they're gonna be like, "Yeah, great, we'll be there in 17 hours. Because that's how long it's gonna take us to get an aircraft from Germany down to Africa. And that the African command headquarters are in Germany. Why? Because you can't get from the east to west of Africa. You have to go through Europe to reach down into Africa. It was that far, but it was something we had never experienced before. Sure, we had a broad baseline of training, but we didn't really understand, at least in Army Special Forces. And then we had a team, a surgical team that was placed there because, well, we'll put surgeons down there. This is in Arlit, in Niger, northern Niger. We had a 4-person team, and that's a senior medic by the name of Justin, who helped originally when we put this together. And although you have a surgical team in that tent, they have weather occurrences, obviously, so you get weathered in with sandstorms. In Colorado, we get weathered in by snow. In fact, the county that I work in, we had what was called Snowmageddon last year, with the entire town on the backside of Pikes Peak, which isn't that far, was completely cut off for 36 hours. Cut off for 48 hours. No power for 32 hours. This is a town that has like 5 casinos in Cripple Creek. About 5 casinos, 4 foot of snow, and they could not move anyone. And so you may have a great plan, and that's all good until the first flurries fall, or the first sandstorm comes in. And so we had a surgeon and an anesthetist, senior medics, nurses, emergency physician, all in those tents. But they were sitting there going, what are we going to do? We are really, really good with a robust system. But that's where, back in 2013, we all got together at the SOMA meeting, and that time it was in Tampa, Florida. SOMA meeting, and we said, we've got a real problem here. And so that's when we started talking about the tyranny of distance. I mean, you probably talked about that, but that was the size of Afghanistan. That was our usual operational problem set. That's the size of the United States, and obviously there's the size of Africa. And so at that point, distance or time of evacuation really became the paradigm for what it is that we built Prolonged Casualty Care around. That's an example of just those concentric circles where the star in the middle is the Ramstein Air Base in Germany, but that's where our evacuation was coming from. That's if they were standing by the aircraft was fired up and ready to go. And you imagine these are no notice, and those folks weren't necessarily sitting there waiting to respond to medical evacuation calls onto the continent. Now I get it, they don't happen that often, but when they do, in a best case scenario, you're going to be able to reach Niger, which is right here. That's right inside the 8-hour ring. Great. Good luck, medic, for 8 hours at least. And my medics are coming back and telling me, what do we do? We're highly trained. We've been through 2.5 years of training. We have all these skills. We can do surgery. We can do this. But I never had to wrap my brain around that. And I also deployed to the southern Philippines, and we fly over literally hundreds of islands that look like this. And our Navy SEAL brothers that our Navy brothers and sisters had to cover down on places like this, because the bad guys don't hang out necessarily in the nice areas, right? You know, how many people in the military get deployed to nice areas, right? Well, okay, National Guard reserves, yes, they get to go to Fiji and other places. But the rest of us get to go to the garden spots, right? But there's nothing here. But if you can imagine, you're going to take a ship, but then you're going to take small boats, and you're going to have to go and do whatever it is that you do. And if somebody gets hurt, or they get shot or blown up or whatever, you're going to have to try to get them off that island. And back in the upper right corner where you see those mountains on that island, that's Mindanao. That's where our surgical team was. And so we had to move them back to there. And again, that flight distance is probably going to be 30, 40 minutes if you're on site to get somebody. And so Africa was the first one we started thinking about, but there are many places in the world. And we're not talking about, other situations. We can talk about urban warfare. We can talk about, again, a snowstorm in Colorado. We can talk about in the Arctic. There's a lot of different places. But the bottom line, and I'll come back to this, the bottom line is human physiology really doesn't change that much. And again, we were good at tactical combat casualty care. When my medics would sit around and think about all the dumbass things that their buddies would do when there was nothing left to do. Of course they're going to drive the ATVs, and of course they're not going to wear their helmets because that's not cool, right? They'll have the Oakley sunglasses on, but they won't have the helmets on, so they'll look good. But then they'll just have accidents, right? Or they'll take their skateboard and they'll take it off somebody's compound there. But then you start thinking about, well, I'm in Africa. What happens if I have snake bites? What happens if they get burned? Or there's a fall? Or a negligent discharge? They're training these guys in how to use weapons. What if they shoot each other? And they started to just think about it, and they said, well, tactical combat casualty care isn't going to get me through that. Or if it does, MARCH, it's going to get me so far. But again, they needed a paradigm to wrap their brains around. And as we looked at this further, we noticed that there are a lot of analogs on the civilian side as well. So it's not just military. These pictures, this could have been last week in Colorado Springs, when we get these snowstorms. I mean, yes, the snow gets cleared pretty quickly most of the time, but we actually have a lot of times where weather will just weather us in. This looks very much where my folks practice right now. This is Australia, but again, there's a lot of open spaces in a lot of areas where you can't necessarily get to a hospital that quickly. So we formed the working group back in late 2013, early 2014. We started in a group much like this, interested personnel. We just passed around a piece of paper and said, hey, if you're interested, put your email on that list. How many people are on that list? I know, like John and some of the other folks. Like that original list, we just started circulating. We started saying, what are we going to call this? We originally thought extended care. It turns out that there's a medical billing code for extended care. It happens to do, with long-term care on the civilian side. What we realized was that the NATO Special Operations Forces Working Group in April of that same year had taken a whole long weekend and defined it for us. And it was a pretty good definition. And so what we decided was, one thing that I was coordinating all this, I had an email list, and I said, let's just keep it as simple as possible. Let's not make up new terms. Well, you'll see how that, over the last 10 years, how that hasn't stuck. However, PFC right there, they just came up and I said, this is great, okay. Field medical care, okay, no kidding. Okay, applied beyond doctrinal planning timelines. Meaning when you roll out the door to provide medical support, you're gonna have a certain amount of kit, a certain amount of training, and a certain amount of assumptions. So if you work in an urban or suburban environment, why would you ever take antibiotics? You wouldn't. There's no reason to take antibiotics. Nobody's gonna get an infection in the 38 minutes at best, or at longest, that you're gonna transport somebody. Why would you do nursing care? Paramedics are never trained in nursing care. I mean, again, and not to say to disparage nursing care of the word, it's just not something where you reassess your patients over time. There's no reason to do that. So that's what we mean by doctrine. And then if you're going to go out on an expedition, sure, you're going to carry other type of things. But when you get outside of that training and those assumptions, what do you do next? The way I explain it to my non-military colleagues, I say, okay, you have a protocol or a guideline. Imagine you get to the end of that guideline, which takes you all of about 22 minutes or 38 minutes or whatever, but you now have an hour and a half to drive to the hospital. What do you do after that? Everybody has a guideline, everyone has a protocol, everyone has a paradigm of care. But what happens when you get beyond that? Oh, and guess what? It's still your patient. You can't hand them off to somebody. Or in the case of Africa, maybe you're the smartest person but you might go to the local hospital. We've all been to local hospitals, right? And it's just like they told you in the briefing, right? Yeah, they've got a neurosurgeon, they've got a CAT scanner. They might not have electricity. The neurosurgeon might be on vacation, but they have it on paper, and then you show up with your patient. Well, you're still having to take care of your patient, at the very least advocating for your patient. And so what we need to do is wrap our brain around the fact that you may be with this person for a while. Really important here, in the middle of this, combat medic or special operations combat medic, we just chose somebody to focus our clinical practice guidelines. So the early clinical practice guidelines are based on a paramedic or a highly trained paramedic. I'll just call them like critical care department. We have since learned that lesser trained people can absolutely provide excellent care. In order to decrease patient mortality and morbidity, the example that I use is if somebody has an arterial injury in the lower leg and you place a tourniquet on it to stop that bleeding, you have absolutely saved that patient's life. Save that patient's life. But then, as we're seeing now in Eastern Europe, playing out that folks are getting a lot of tourniquets and they're not coming off. And that tourniquet now becomes life-threatening, or at the very least, increases the patient's morbidity. So the things that we do to save somebody's life in the first 15 minutes, which work just fine when we could get them to a surgery within an hour, may be causing unintended consequences further down. We all learned in ATLS, well, not all of us. I learned in ATLS 20 years ago this whole thing about hypotensive resuscitation. Just don't pump their blood pressure up too much. But if they remain hypotensive for a very long time, what's happening to the kidneys? What's happening to the liver? What's happening to the critical end organs? Well, we don't really know because we can get them to the hospital and start resuscitating them. What if we can't? We may be creating morbidity. So what we had to do was come up with guidelines that did the so what and the next and how is it that I can best take care of a patient. Okay, that's a pretty wordy idea, but one of my critical care colleagues, Dr. Doug Bowell, was co-author on a lot of these. He said, look, this is just treating a patient you know needs to be somewhere else for longer than you want to. You may not have the logistics, you may not have the training, you may not have the experience, but you need to treat that patient. That's all prolonged field care is. The U.S. Army Rangers, who are very, very, very regimented and very, very good at tactical combat casualty care. When you ask them, when does prolonged field care start? What do they say? When they call for evacuation and they're told no. Or hold on, or the situation needs to mature a little bit, we can't get you support right away. That's when they go into prolonged field care. They've done their life-saving activities, they've called their 9-line medical evacuation, and they're told no. That's when you go into PFC. So I presented this at a number of different meetings. I spent about 5 years walking around telling the story. I gave updates at SOMA. But as I did and the word started to get out, people started to say, hey, can you come talk to this other audience? Can you please go around? And I just kept giving the same, and again, if you've heard this before, which you may have, this is very similar to what I would tell other people. But it started to kind of trickle out. And as it trickled out, some of my colleagues who were hospital-based or had deployed a lot in the joint trauma system started to listen. If you know Colonel Stacy Shackelford, phenomenal trauma surgeon, great human being, and highly productive with medical writing and doing really, really good trauma care science. And she was the one who said, hey, we need to come and talk to you and your colleagues. We have 44 clinical practice guidelines for surgeons. So once they get to the hospital, they had a lot. Because we had a lot of surgeons that were being pulled straight out of the hospital, just general surgeons. And most general surgeons don't do trauma care in the United States. That's probably true, in your hospitals as well. But then they would throw in them horrendous burns and amputations and vascular procedures. And they said, we need to write guidelines, evidence-based guidelines as to what they do. She says, now we have 44 of these for surgeons. We don't have any besides the TC3 guidelines for pre-hospital. So she said, let me bring some smart people out and start talking to your medics, the special operations medics, and find out what you need. And that's really how we started to do the clinical practice guidelines. When we first wrote the first position paper, we talked about the 10 capabilities of prolonged field care. That was the first position paper Justin and I wrote. And what the capabilities were, now I'm a doctor, right? So what makes me special? The stuff around me makes me special when I practice. The fact that I can get a CAT scan, the fact that I can get a complete blood count and a blood gas and a blood porcelain level and tell you what that means, that's what makes me smart, because I have all those things around me. So I thought about capabilities as stuff. But what Justin said was, no, capabilities aren't stuff. Capabilities are fundamental things that we need to bring to a patient, a sick patient. And we need to do it in a generic sense. We can't say, well, somebody with chest pain or having a heart attack needs to have an EKG. No. We need to have diagnostics. We need to be able to get a good history and physical. We need to be able to do nursing care. We need to bring a certain amount of pharmacology. And then he said, you know what? In these situations, we accept risk all the time. We accept risk in what we pack. So if I have a small backpack, I can only take certain things. I'm not bringing a ventilator, and I'm not bringing a ProPack monitor necessarily, especially if I'm doing trauma care. So I'm going to accept risk in my monitoring. I'm going to accept risk. And he said, what we need to do is we need to figure out, he's like, at an absolute minimum, if we say that we want to secure an airway, like no kidding, secure an airway, we need to define what that minimum is. He says, but then when I have a truck, or I can bring somebody to a surgical suite, now I can have something better, and I can actually do things best in this way. And so when he wrote the capabilities, he came up with this concept of minimum, better, and best, which has stuck all the way through the CPGs, and it just makes sense for people. And so when you're thinking about the context of care, whether you're practicing out of a ruck or an 8-bag, all the way through a house, if you've heard this truck, house, and plane, it's just a way of cross-leveling capabilities with the context of care. So really interesting that he put that out, and that's really stuck, because it really talks about how you provide care at an absolute minimum. So if you're going to say you're going to secure an airway, I would say you should be able to do a cricothyroidotomy, put a cuff, tube, and a trachea so that you can really secure an airway if you need to. And then if you're able to do rapid sequence induction with medication-assisted intubation and a ventilator, great, yeah, do that. But at a very minimum, if you're saying you're going to secure an airway, you're going to cricothyroidotomy. When we looked at these different capabilities, one of those is physical exam and diagnostics. There are plenty of medical textbooks on physical exam and diagnostics. We didn't have to recreate that. We didn't have to recreate the first aid or tactical combat casualty care. But what we had to do is we had to take into account, and burns was an excellent example. There are burn surgeons and subspecialties. We had to take into account, that's great, but if all you have is a few dressings and some crystalloid solution, how do you treat somebody? There's a gap there in prolonged field care. So when we wrote the clinical practice guidelines, this is just an example: burn wound management, ocular injuries, analgesia and sedation. These are not comprehensive. These address gaps in this operational environment. Okay. These address gaps in the capabilities. We wrote 12 or 14 of them. We wrote them between 2014 and 2022. But that's what the clinical practice guidelines are. In many of the capabilities, you can absolutely do what you normally do. Do a history and physical exam. We didn't have to write that in prolonged field care. But what we did have to do was address the gaps as we saw them. And so this is not comprehensive. Okay, so that was the early years. So now I just want to talk about the present. And the present, I think, really is between 20, this is in US terms, okay? US military, joint trauma system guidance. The present really started in about 2020. Not because that was when COVID was. But in 2020, our military, JTS, took what I think was a huge leap forward, but also take kind of a step back in the pace of putting out guidance. So what they did was they brought the Prolonged Field Care Working Group, and they brought it over to the JTS. And they said, we are going to formalize this. We're going to make the Prolonged Field Care Working Group. And that was run by Dr. Jamie Reesberg, Sergeant First Class Paul Lose, and now Sergeant Major Michael Renly. And those three guys got together, again, a group of subject matter experts, and they said, we are going to write Prolonged Field Care as a working group. And then they got everyone together from all the services, and what did the Navy say? The Navy says, we don't work in the field. Okay, so let's spend 6 months trying to figure out what the hell we're going to call this now. And they came up with Prolonged Casualty Care. So Keenan's first rule of now making shit more confusing, it got a little more confusing. And not to disparage the great work that they did, but that's how Prolonged Casualty Care came out. So what they decided was, let's make something for all the U.S. military. We're going to pull it out from under SOF, and we're going to turn it in for all the military. And to appease everyone else. Now, Space Force wasn't around right now. I don't know what Space Force would call it. But they didn't get a vote. But everyone else did. Air Force, Navy, Army, Marines. Marines are part of the Navy, but they never admit it. So bottom line is, they came up with Prolonged Casualty Care. And they made some certain assumptions of Prolonged Casualty Care. So, in my mind, keeping it as simple as possible, Prolonged Casualty Care is Prolonged Field Care in 2021 when this came out. It's a new terminology. Where this is important for you is the fundamental assumption is that the person practicing this is trained and equipped for Tactical Combat Casualty Care. Stop. Trained and equipped for Tactical Combat Casualty Care. So they're rolling out with a backpack that has only Tactical Combat Casualty Care stuff in it. They're not necessarily carrying extra antibiotics, pain medicines, airway equipment, or anything else. I would submit to you, if you were in a non-military role, you're not rolling out with a Tactical Combat Casualty Care kit. You have other things. Pre-hospital, most pre-hospital ALS providers are going to have quite a bit more to manage the airway, quite a bit more pharmacology. So if you open up the PCC guidelines and you say, well, where is my, I don't know, long-acting opioids like morphine and Dilaudid? I wondered that. By the way, and again, I'm not criticizing, I'm just telling you where that is right now. It didn't have a lot of meat on it because it was for our basic medic requirement, and maybe a little less relevant to what you were used to looking to in the PFC CPGs. We then put together a curriculum. It was only a curriculum shell. We put together a curriculum, and as we went through the curriculum, we realized that there were a lot of inconsistencies in that first set of guidelines. Me and people behind the scenes over the last couple of years, have rectified some of those inconsistencies. In version 2.0, the final version is with the Committee of Tactical Combat Casualty Care for vote as of this past month, and we hope to have version 2.0 of the Prolonged Casualty Care guidelines put out. And that is the official guidelines for prolonged field care in 2025. It doesn't look, it's a different format, but there's not a lot more meat inside of it. Again, because it's written for a 21-year-old, I'll call him kid, because my kids are that old, 21-year-old kid coming out of four months of medical training and what it is that that kid is going to do when they get deployed. So it's going to be probably at a much lower level than what you're used to looking at. But we think in the future of modern warfare is that the kids are going to be providing medical care. We know from experience that there aren't a whole lot of paramedics still alive in Eastern Europe that are currently in conflict, and we're putting people out there with the equivalent of what we would consider a combat lifesaver for the military. The best site to catch up on any of these guidelines, clinical practice guidelines, Tactical Combat Casualty Care, the best site is Deployed Medicine. This is a website that is run by the Joint Trauma System. Those of you that know Monty, Harold Montgomery, he actually runs this behind the scenes. This is where, if you're going to go and get U.S. military guidelines, I would get there. I mentioned to you that last year we put out a curriculum. All this is a Prolonged Casualty Care curriculum. It's got learning objectives. It does not have the course like you're used to seeing maybe in Tactical Combat Casualty Care, if you teach that. But that's what's up there. In there we have those things. And again, if you go to Deployed Medicine, I copied this probably about 3 months ago. You've got skill instruction, skill assessments, worksheets. Great if you're training this to military. So that's all military and where we are with the military. This started with the military. In parallel to this, in 2019, at the Australian Tactical Medical Conference, Dr. Reed Smith came up to me and the CEO of Ragged Edge and said, hey, Roger Dale, he said, hey, you know what we did for Tactical Combat Casualty Care to a committee of TECC? He said, can you guys do that with prolonged field care? We think, we being the non-military community, thinks that there is a place for prolonged field care training on the non-military side. And we talked for a long time with him, and I talked to some of his colleagues, and that we got a lot of feedback as to the problems with TECC, and a lot of it had to do with the quality and quality control of the education and training of TECC. They put out a set of guidelines. They handed out a symbol which said you're affiliated with TECC. Now go out and do TECC stuff. And they taught TECC. They said that wasn't the best model, they said, but we're understaffed, we're learning. And so then we went and we looked at other organizations that put out courses. So we went to the Society of Critical Care Medicine. This is in the US, Society of Critical Care Medicine, because they have something called FCCS, Fundamentals of Critical Care Support. We went to a lot of the folks in the Wilderness Medical Society, and we looked at advanced wilderness life support, which I've been teaching for many years. We looked at some other models, myself, Averick, Roger, some other folks. We said, how is it that we can affiliate with one of those to put together something about prolonged field care? And the bottom line was there was a lot of good practices and a lot of bad practices. So we decided to do the incredibly easy way around it, which is to create our own company and to come up with that. I say that tongue in cheek. And so then we came up with a course called Austere Emergency Care. At the risk of making another 3-letter acronym for this, we decided we were going to make something for the civilian side. And so what we did was we took what we thought was I won't call it comprehensive, but we put together an introduction to prolonged field care, essentially for non-military type audiences. And what we did was we took our civilian course and we went on the road in Colorado, just because that's where I live, and we put it in front of civilian. What we wanted was old, crusty paramedics that had been practicing for a long period of time. We wanted to put it in front of them to get their feedback. And I'm describing some of my colleagues from Gunnison because they actually hosted us down there for the second course we ever ran. We put it in front of them. And Mr. C.J. Malcolm said, that's great, I've been to this is what we said on the phone. He said, I've been to a lot of these courses. Okay, Doc, what's so special about this? I'm like, just, will you have us down there? And they actually hosted us down there. We put it out there, and then we got robust feedback. And it turned out we didn't have to tweak the curriculum too much to make it applicable to folks. And so I don't want to put words in their mouth, but they're hosting the course down there again in a couple of weeks. So I think they think it's okay.
We were also the first to host it, Doctor, not the second. Eagle was the second.
Eagle was the second. Okay, we ran it once ago. Okay, you were the first to host it. You were the first to host it. When we hosted it, actually, Eric and Eric flew in from Europe to Colorado to see the course. And so they became early adopters. But I thank you all for the faith, I guess, in the curriculum. But anyways, what we did was, looking at this, what we said was we're going to put together something we're going to do something that is for BLS and ALS. We're going to base on the CPGs and best practices. But what we did is we designed it as a continuing education course. My intent, because the U.S. paramedics need 60 hours of continuing education every 2 years, my intent was to have an off-the-shelf course that some people chose to train in as a continuing education. So again, this is a continuing education. It's an experiential course. It doesn't expand your scope of practice. The way that I tell other people is you bring your protocols, you bring your guideline, you bring your training, your credentials, and your kit, whatever you would normally go with. And what we're going to do is we're going to show you ways of expanding your capabilities through discussion formats, through practice, through hands-on. We're going to show you additional ways and 1 or 2 things to expand your protocol. We're going to review practical labs and how to do cricothyroidotomies. We're going to show you how to do finger thoracostomies if all you do is needle thoracostomies. We're going to have you chart vital signs. We're going to have you do nursing care skills and build ketamine drips for pain control. So we're going to show you just some things, and then what we're going to do is we're going to put you into a full patient care experience on the last day. So that was our intent with this course. And this was designed for the average pre-hospital provider, okay? It's not for critical care paramedics, it's not for flight paramedics, it's not necessarily for anesthetists that ride on ambulances all the time. This is for the average person, alone and unafraid, who finds themselves in a situation beyond what their guideline or their protocol shows them to do. I had mentioned also that we brought what is now called the Prolonged Field Care Collective under our nonprofit. And so you may recognize, if you don't recognize the face of Dennis, you may recognize his voice. That's why he is on the radio, probably. He usually has a baseball hat on. And then Paul, so Paul Lose, who formerly Sergeant First Class, who retired last year. He works with me and teaches quite a bit. But these are the gentlemen really that are running the website and the podcast with the help of a few of us, but they're really the faces of that. But we were able to bring that under a nonprofit as well. Okay, great. We've been doing this now for 12 years, and this is the U.S. perspective. You know, what are our challenges in prolonged field care? Well, our challenge right now is we're experiencing what's called the Walker dip. I know that is not the case for some of you. Some of you are in the thick of it in different places, whether that be Israel, whether that be Eastern Europe. But right now, we as an American society have pulled back from conflict a lot. Good or bad, I'm not here to discuss politics, but we're experiencing what's called the Walker dip. So, General Alice, have you heard of the Walker dip? Just by show of hands. Okay, so the Walker dip basically is, I think it's a general, a brigadier in the UK, described this phenomenon that we get really, really, really good at medical care when we're in conflict. And the minute we stop active conflict, we pull back all of our resources, we forget the lessons learned, and we go down into a period where we are not as prepared to take care of patients, right? And so you see this dip where the proficiency and experience leaves the military. That's just the way it is. And then what happens in the next conflict? We have to relearn all those lessons very quickly. So we are now, we don't know where we are in the dip, but we're pretty far into the dip right now. We have a lot of people that have not deployed. I mean, thank goodness we're not taking casualties like we were, but we just don't have that experience right now. More importantly, we're not putting time, resources, and energy towards advanced medical training. And what's the result of that? We are not mastering the basics. Right now, if I were to teach a class, there is a lack of TECC or TC3 fundamental knowledge. We ran a course in Poland, Special Operations Medical course in 2017 when I was stationed in Europe. And they said, can you come and talk about the importance of prolonged field care? I said, yes, but I'm going to tell you not to do prolonged field care training. I'm going to tell you to make sure that every single person can do tactical combat casualty care. First aid, they can do it well. They make sure their buddy can do it well. They can do it at night, they can do it in the dark, they can do it in the cold, but they can do tactical combat casualty care. Because I would challenge any military unit that I've seen who says they're proficient to actually be able to do that. I would challenge that. And right now we're putting less emphasis towards that. So if you said right now today, I'd say go back and see how good your folks are at first aid. This isn't wazoo and fancy stuff. And I know, I don't want to disparage some of the advanced workshops because you all are at a much higher level. But bottom line is if you can't do first aid, if you can't place tourniquets correctly, there will be no prolonged field care, all right? What we're really looking at, what we think, is extending the golden hour. So the golden hour, and we published a paper last year, a few years ago, in the Journal of Trauma, actually proving that the golden hour is a thing. Like we kind of said this, if you got to a surgeon within 60 minutes, you actually had decreased mortality, period. There's one thing that we think, one thing that can extend your lifespan or your mortality beyond 60 minutes. And we think that's early resuscitation with whole blood. Not a shocker for a lot of you. But I can tell you right now that there's in the US, we've got 1.5% of our pre-hospital services that currently have access to whole blood. 1.5%. The military, for the most part, is not proficient in how to give whole blood. We have clinical practice guidelines. The JTS is putting together a curriculum right now for walking blood bank. But I can tell you, for proficiency, we're not there yet. Some of our special operations forces, there are some exceptions. The U.S. Army Rangers and some of the associated units are at the point of being highly proficient. If somebody gets shot or blown up, they can have a unit of fresh blood drawn from another soldier all by non-medical personnel within 12 minutes. If they do a radio call, they can say, Rollo, Rollo, Rollo. What happens is, a guy in a machine gun turns, pulls his blood donor kit out from behind his body armor, and hands it to his buddy while he's still in the machine gun, holds his arm out, they draw blood off. Non-medics, they tie off that blood, and then they run over to the medic and say, hey doc, here's your unit of blood. They can do that in 12 minutes. I would challenge most other units probably cannot do that. Why do they do that? Because they take a lot of casualties and they train like crazy. But until we are really good in tactical combat casualty care, and we are really, really, really good and efficient and facile in whole blood resuscitation, if you don't know how to do those two things, again, I would say there's no reason to train in prolonged field care. Right now, even though we're the ones who write the guidelines and do that, being the US Joint Trauma System, we are not proficient at that. When you put people through prolonged field care training, they understand where their gaps are. And what we're coming down to is that a lot of times it is a lack of logistics, especially if we're talking about mass casualty incidents. A lack of logistics. If you're able to plan for and war game logistics, and you can get better at logistics, delivering logistics, that's a huge part of our planning right now that medics didn't have to worry about before. If you're good at those other things, then yeah, you need to master the basics. You need to be able to take 2 sets of vital signs. When we started doing this, people said, oh, special operations. We're not special. We don't do spooky stuff and black nylon and Velcro. We don't kick indoors and fast rope with a knife in our teeth, returning fire while we're putting on tourniquets. I said, yeah, prolonged field care, that's really, really high-speed training. It's stuff like, taking 2 sets of vital signs and writing them down and comparing them to one another. That's pretty sexy stuff. It's putting a pad under, bending somebody's legs or sitting them up a little bit so they're more comfortable. That's pretty high-speed stuff. But really, there's some really basic stuff in prolonged field care that can absolutely make a difference. Just because it started with special operations doesn't mean it's special. It's basic good medicine. And then lastly, some of the challenges that we're looking at is the challenges of what we're calling LSCO or large-scale combat operations. So, although we're writing a lot of guidelines and we're putting out good guidance, these are still challenges for us. We've been through 2 decades of conflicts. We put out, I think, some pretty solid guidelines. The reason I think they're all solid is that other people who were unintended when we wrote them are adopting them as law, as is the country of Ukraine, is basically adopting that free hospitals law as tactical combat casualty care. That's a pretty awesome challenge, but even though we're the ones maybe that are putting this out, that honestly just I think because we're resourced a little bit better, not because we know better, we're having a hard time keeping people up to speed. And so I would say if you're interested in this, please think about simple things that matter when you're practicing that. So I'm just going to do a couple slides on what we think is the future. Avery and John said the past, the present, and the future of prolonged field care. Again, this is from a U.S. perspective. I realize that you may have very different perspectives. This is also very heavily military weighted based on what we have. The current practice for prolonged field care as we described it, when I was talking about those capabilities. Inherent in this is we're trying to get out of prolonged field care. We are trying to move a patient back to first world or higher level of care. You're taking care of someone that you know needs to be somewhere else. You're trying to get them to that somewhere else so you can get out of prolonged field care or prolonged casualty care. It's continuous evacuation. What we're seeing, at least in Eastern Europe, is essentially, I think this was said best, they are stuck in care under fire, tactical combat casualty care. There is no prolonged casualty care or prolonged field care as we envisioned it. It is prolonged. For that person on the ground, it is prolonged. I'm not saying that it's not a problem. It is absolutely a problem. The problem is they're stuck in care under fire. For any of you that are familiar with tactical combat casualty, you put on tourniquets, stop bleeding, and return fire. That's all you can do because you're under fire. Unfortunately, with drone warfare and what we're seeing, and the fact that medical personnel are being targeted, they're stuck in care under fire. As we envision prolonged field care, this doesn't help a whole lot as to what do I do. Get underground and move backwards. Oh, no shit, doc. Like, I'm the one getting blown up. Yeah. I'm sorry, and I don't mean to be flippant about it, I'm just saying they're stuck in care and fire. So when people say, well, you know, you can't do all this fancy, you're right, you can't do all that stuff. We've got some serious issues to overcome. Current practice, a lot of our training, at least for military, is extending the golden hour by doing damage control resuscitation, or as the Thor group calls it, remote damage control resuscitation. But what happens when you have multiple patients, multiple serious patients? It really becomes a triage problem. When we envision prolonged field care, we were usually dealing with 1 or 2 sick people. I said, yes, of course you do triage. Of course you do triage. And you figure out who that sick person is that you're going to focus on. But what happens when you have multiple sick patients? And what happens when you have to keep them in place? I think we're going to have to really look at science to decide, with limited resuscitation, that old concept of responders, transient responders, non-responders, the description of shock or hemorrhagic shock. We're going to have to look at that. Limited and continuous triage based on reassessment. We're going to have to get really good of taking people who have very little clinical experience and giving them guidelines as to who do you have to say no to and who are you going to continue to resuscitate. We didn't really have to deal with that in prolonged field care. Time is actually a huge triage assessment. Right? So we actually did a study that looked at, of those people that were going to die, 78% of them died within the first hour. That's where you see the first beat. 90% of the people who are going to die were going to die within 4 hours, meaning time could be used as a triage tool. But what happens in that first 4 hours? How do you make tough decisions? We're not very good at training that right now. And that's what we're going to have to do when we have multiple casualties. As I mentioned, current practice was having limited logistics, moving with that one patient. Current prolonged field care guidelines of practice. Now we're going to have to look at logistic resupply is a major planning factor when we're looking at medical operations in large scale combat operations. We had talked about telemedicine as being that bridging mechanism. You may see somebody, you may not have that experience, but being able to call somebody up, and we practice that during our prolonged field care training. If we have limited communications because we don't have air dominance or because we have electronic warfare, we're going to have limited comms. In current practice, I would say you have known mortality estimates. If you have somebody that does not make it to a surgeon within 1 hour, we have really good data. And actually, we have a prolonged casualty care study going on in South Africa. University of Colorado does. We're looking at many, many trauma patients. You've got about twice the mortality if you're in the field for longer than 4 hours. Twice the mortality. But that's usually predictable. The mortality numbers aren't very high in South Africa, in our study population there, CU study population, but we saw that in the military as well, where we had about 10% mortality in combat. If you were in the field for 4 hours or longer, you had about 20% mortality of major trauma. But now we're talking about something called expectant casualty care. Again, getting back to triage. Expectant casualties are people that you temporarily decide you're not going to do life-saving care on because you're going to do it on somebody else. How is it that we are going to train our pre-hospital providers to manage an expectant casualty care? How are they and their team members and their leadership going to talk about, conceptualize, deal with, at the time and afterwards, calling people expectant? And we call it expectant casualty care on purpose because basically it doesn't mean you're stopping caring for a patient. I have a whole lecture on this. But caring for a patient, it's just a different type of care. You're not going to do active resuscitation, but you can care for a patient. This is something we need to train the 19, 20, 21-year-old kid, I call them kids again, coming out of our high schools and joining the military. Because we're going to be saddling them with a tremendous psychological responsibility of calling people expectant. I think we have an obligation to train them how to make some of those decisions. That is not necessarily something that we had to deal with when we had prolonged field care and we had communications and stuff. So that's kind of the future. So as my colleague, friend, and founder of the Thor Group, along with Phil Spinellis, if you know Dr. Gearstrand, says, you're entitled to your own opinion, but you're not entitled to your own physiology. So what it means by that is you can sit and argue about what you think about resuscitating traumatic patients, but the bottom line is human physiology is human physiology. I've said that before. Prolonged field care, or prolonged casualty care, is based on sound medical principle. I would submit to you, it is the what you're going to do when you find yourself in that situation. The operational situation is the how you're going to do it. So whether you're doing maritime rescue in Norway, whether you're doing high-angle rescues in Colorado or the Alps, whether you're in sub-Saharan Africa, that's going to dictate how you're going to do that. The what you're going to do is prolonged field. It's good medical practice with limited logistics, utilizing simple communication strategies, simple patient care strategies, and that stuff. Good medical practices are still good medical practices. When we teach austere emergency care, we've done it, like I said, in Norway, we've done it in Colorado, we've done it in New Zealand. They are slightly different environments, slightly different organizations with different missions. But they're all going out to provide medical care, and we're teaching them how to deal with their kit and their protocols and how to extend that further using sound medical practices borrowed from the literature, borrowed from experience. Human physiology is human physiology. We used to tell a commanding general, it's just because you're on the continent of Africa, you don't bleed slower than you do in Afghanistan. If you're bleeding to death, you're still bleeding to death. Blood doesn't come out slower because you're geographically somewhere different. Human physiology is still the same. So I still go back to just mastering the basics. Simple capabilities done well work well. Can you train for prolonged field care? Look at the list of essential capabilities. Look at the minimum and better and best, and based on your own self-assessment, figure out where your gaps are in training that. I'm a hospital-based physician. I'm not good at nursing care. I'm certainly not good at starting IVs. That's probably what I need to work on. I'm pretty good at history and physical exam because that's what I do. So maybe I don't need to focus on physical exam, but I probably need to focus on nursing care. And conversely, if you're a nurse, there may be other things with patient packaging. Maybe it's a bad example. I'll just say pre-hospital patient packaging if you don't work in the pre-hospital side. And so if you want to get better at prolonged field care, look at the capabilities, do a self-assessment of you or your unit, and practice those things that you don't do routinely. Everyone's going to be a little bit different. One thing that my medics had to figure out when they went to Africa is that their evacuation plan was on them. So no one was going to hand that to them. Take responsibility if you're responding. If you're responding to a disaster or you're going to a lone site, take responsibility for the fact that you're going to be your patient's best advocate until they get to wherever they're going to get to. So if somebody says a helicopter is going to come, okay, great. Figure out what's on that helicopter. But take responsibility for that person's evacuation in the logistics, in the operations. For our new graduates and folks that are out there and excited about this stuff, look for gaps in the knowledge or in the literature or the best practices and make that your professional hobby. The reason that we were able to push prolonged field care as quickly because it was a real problem that we had. It's not really a hobby. I make a joke like, oh, I got these hobbies now, but it was an operational imperative. Like we went from Iraq and they turned around and said, go to Africa. And me as the medical director and my medics were like, holy crap, like that's our job now. That's a real problem. When you get to your jobs or if you're at your jobs and you find that there are gaps, ask questions and get after it. If it's not in a guideline, if you don't have the correct medicine or tool to do something, start to dig into that. Figure out what the literature says. I bet you're going to find a ton of gaps. And people say, hey, how do you get into academics, right? I'm not really an academic per se, but just find something and get really, really, really good at it. And what you're going to find is if you start digging into stuff, you're going to realize there's a huge amount of gaps in it. And then build a coalition and try to get after it. But that's really how you can get after this professional. And again, get really good at the things that save lives. In the tactical trauma sense, if you're in the military, we feel that is Tactical Combat Casualty Care and TUCC, and then remote damage control resuscitation. Get really good at those, and then practice all the other stuff for folks to do that. So in summary, I talked a long time. It wasn't like we were sitting around and had nothing better to do. Operational need drove us, and just drove the U.S. Special Operations, because at any time we're in 60 to 70 different countries out there, to first formalize and describe it. We had the problem, so we had to fix it. That's how it came up to start with. It wasn't anything new. We just gave it a definition, and decided to focus on it. And that's how we came up with prolonged field care. Scientific peer review guidelines absolutely exist. If you're wondering how to find those Joint Trauma System Clinical Practice Guidelines, or CPGs, go to prolongedfieldcare.org. There are links on there, and you can actually take you to those. Joint Trauma System Guidelines, I told you about the limitation, I told you about them. They're out there. Familiarize yourself with them if you're interested. If you're interested in it, I will advertise to say there is a course called Austere Emergency Care. And Eric and Abrick have taken that on to teach it. There's a course in Poland, next month? Next month, I think it's full. But there's actually quite a few courses that are popping up now. It's relatively new, but it's based on all of this. And those of you that have been through it, I think, hopefully think it's pretty good. I think it's pretty good. It's an introduction to this. I'm biased, of course, right? But I'm just going to say, hey, future warfare and operational situations may limit any good medical care, right? The enemy has a vote, as we say in the military, right? Some of this PFC stuff may be pie in the sky based on your operational situation. But practicing the best practices, I would say, in austere environments will absolutely open up your aperture. If you want to go back to your unit, I just tell people in the military, like, hey, we want to know how to train for prolonged field care. I'm like, well, do you train in Tactical Combat Casualty Care? How long does that last? Well, a scenario lasts 20 minutes, 30 minutes. Just take a scenario and make it last 3 hours and see what happens. You'd be amazed at what happens, because everyone's kind of like, I don't know what to do. It's 21 minutes. I don't know, write down a set of vital signs, talk to your patient, get a history, do good medicine. And I think that really begins to open up people's apertures. The other thing we found was when we ran these exercises, not only did we show them that simple things make a difference, but we actually increased confidence. And if you increase confidence in both medics and non-medics, you psychologically lower risk. Because people then begin to understand, I can do this. I can do this for an hour or two. I know what happens after Tactical Combat Casualty Care. Wow, okay. But by opening our apertures and making people think, you actually can lower risk psychologically. So anyways, that's the website, prolongedfieldcare.org or pfcare.org. Our nonprofits at austerecare.org. I just pulled that up for them a couple hours ago, so I guess Paul changed the picture. Now we got some warfare stuff, because there's this thing called global warming. There's this thing called the North Pole. It turns out that bad guys can get to it a lot easier. So I know our Scandinavian brothers and sisters tell us that. They're like, yeah, no kidding. We've had that problem since, 200 years. But we just realized that Alaska is actually now, we can get to it. And Alaska happens to be really close to somebody else we all don't like. So that. Anyways, so that's the website. So anyways, I've talked for a very long time. I apologize. I don't know if that's what you wanted either, but any questions, discussion, concerns?
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.